Pituitary apoplexy. Etiology and pathophysiology. Clinically apparent pituitary apoplexy usually results from extensive infarction of a pituitary adenoma with hemorrhage. In about 50% of cases the event is spontaneous and the pathogenesis is not known. 1/4 of all cases are associated with arterial hypertension, and occasionally it is also seen following head trauma or dynamic testing of pituitary function. Patients on anticoagulation are at increased risk, and prolactinomas treated with dopamine agonists often show signs of hemorrhage on follow-up MRI, although many of these episodes are clinically silent. Epidemiology. The incidence of clinical apoplexy in surgically treated pituitary adenomas has been reported to range from 0.6 to 9.0%. Although it can occur at any age, the mean age at presentation is 45 years. Clinical presentation. Common. The classical presentation is with sudden onset retroorbital headache and visual disturbances, including reduced visual acuity, visual field defects, photophobia, and ophthalmoplegia, most commonly due to a unilateral third nerve palsy. Symptoms may evolve over hours to days and may be mistaken for those due to subarachnoid hemorrhage. Uncommon. Occasionally the onset is more insidious, with nausea and vomiting, meningism and an altered level of consciousness. Symptoms of hypopituitarism or hyperprolactinemia, including chronic lethargy, reduced libido, oligamenorrhea or amenorrhea, impotence and galactorrhea may also be present. Physical signs. Common. Visual field defects and reduced visual acuity, together with ophthalmoplegia, third, fourth, or sixth nerve palsies, are common. The conscious level may be reduced. Uncommon. Signs of underlying pituitary disease, e.g. acromegaly, are occasionally present. Investigation. An urgent MRI, or CT, scan of the pituitary fossa should be performed. If this fails to demonstrate a pituitary hemorrhage, angiography may be necessary to exclude an intracranial aneurysm. There may be elevated numbers of red blood cells in the cerebrospinal fluid or even a frank aseptic meningitic picture. Blood samples for basic tests of anterior pituitary function should be taken, including cortisol, thyroid function tests, prolactin, luteinizing hormone, and follicle-stimulating hormone, and estrogen or testosterone. Treatment. Emergency. Once the diagnosis has been considered, anterior pituitary dysfunction must be assumed. Establish venous access, taking bloods for urea and electrolytes, glucose, and cortisol, and give intravenous hydrocortisone, 100 mg, immediately prior to establishing on regular replacement. Fluid and electrolyte balance should be maintained. Surgery. Urgent decompression is indicated if there is compression of the optic chiasm with visual loss or in patients with reduced consciousness or hemiparesis. In other circumstances a conservative approach may be adopted, particularly if there is no progressive neuroophthalmic deficit. Unlike the optic chiasm, the third, fourth and sixth cranial nerves are surprisingly resistant to compression, and spontaneous recovery of function is common even in cases managed conservatively. Hormone replacement. A full endocrine evaluation should be made postoperatively, and appropriate hormone replacement therapies instituted with long-term follow-up. Complications. Transient postoperative diabetes insipidus is common. Overall mortality rates are not known.